Hello everyone, this is Marwan from the Daily Pharma channel. Welcome to my new YouTube series titled Drug Battles, Head-to-Head Comparison in Pharmacology. In this first episode, we will dive into SGLT2 inhibitors, comparing their mechanisms, efficacy, side effects, and unique benefits. Whether you are a healthcare professional or just curious about medications, join us to make informed health decisions. Don't forget to subscribe Daily Pharma channel and hit the notification bell for the latest episodes. SGLT2 inhibitors are a group of oral anti-diabetic agents that are used in the treatment of type 2 diabetes mellitus. They reduce glucose reabsorption by inhibiting sodium glucose transporter 2 in the proximal tubule and lower the renal threshold for glucose, thereby increasing urinary glucose excretion, as a result reducing blood plasma glucose level. The SGLT2 inhibitor class consists of 4 drugs: ertugliflozin, empagliflozin, dapagliflozin, and canagliflozin. To better understand their clinical applications, it's essential to first examine the key differences in their pharmacokinetic profiles, which include parameters like absorption rates, bioavailability, protein binding, and half-life. In terms of absorption, the peak plasma concentration of ertugliflozin has the quickest absorption, which is only 1 hour, followed by empagliflozin at 1.5 hours and dapagliflozin at 2 hours. Canagliflozin shows a variable absorption time between 1 and 2 hours. For bioavailability, ertugliflozin stands out with the highest at 100%, while empagliflozin and dapagliflozin both have 78%. Canagliflozin has the lowest bioavailability at 65%, indicating less systemic exposure compared to others. When it comes to protein binding, canagliflozin has the highest level at 99%, meaning it's largely bound to plasma proteins. Ertugliflozin follows with 93.6%, dapagliflozin with 91%, and empagliflozin has the lowest at 86%, which may influence how these drugs interact with other medication. Regarding the half-life, ertugliflozin has the longest half-life at 17 hours, making it the most long-lasting, while dapagliflozin and empagliflozin are similar with half-lives of 12.9 and 12.4 hours respectively. Canagliflozin has the shortest range, between 10 to 12 hours, suggesting it may require more frequent dosing. The percentage reduction in HbA1c is a key indicator of the efficacy of SGLT2 inhibitors in controlling blood sugar levels in diabetic patients. Based on the findings of a 2019 systemic literature review and network meta-analysis by McNeil et al., the effectiveness of these drugs varies depending on the dosage. Canagliflozin demonstrates a dose-dependent effect, with the 100 mg dose leading to a 0.74% reduction in HbA1c, while the higher 300 mg dose provides a more pronounced reduction of 0.94%. Similarly, dapagliflozin also shows improved efficacy with the higher doses. The 5 mg dose reduced HbA1c by 0.77%, while the 10 mg dose achieves a slightly better reduction of 0.89%. Ertugliflozin stands out with the greatest effect on the HbA1c reduction. The 5 mg dose results in a 0.99 reduction, and the 15 mg dose delivers the highest reduction among the group, lowering the HbA1c by 1.16%. Lastly, empagliflozin shows a similar pattern, with the 10 mg dose reducing HbA1c by 0.74 and the 25 mg showing the slightly greater reduction of 0.85%. According to available data, SGLT2 inhibitors offer several additional pleiotropic effects, including cardioprotection, weight loss, a reduction in heart failure events, and renal protective effects. As a result, empagliflozin and dapagliflozin are approved for the treatment of type 2 diabetes mellitus, heart failure, and chronic kidney disease. In contrast, canagliflozin and ertugliflozin are approved solely for type 2 diabetes mellitus. Now we will go to the details regarding their effects on the mentioned conditions. Firstly, regarding the cardiovascular effects, several SGLT2 inhibitors have shown significant reduction in the cardiovascular events compared to placebo. Empagliflozin reduced all-cause mortality by 32% and cardiovascular death by 38%, leading the FDA to approve it for preventing death from cardiovascular diseases in adults with type 2 diabetes mellitus and existing cardiovascular disease. Canagliflozin showed a 14% reduction in major adverse cardiovascular events, while dapagliflozin reduced the risk of cardiovascular death or hospitalization for heart failure by 17%. Ertugliflozin, however, has not yet shown a statistically significant reduction in cardiovascular death, heart attack, or stroke. Secondly, regarding the heart failure effects, the current evidence indicates that SGLT2 inhibitors are highly beneficial for patients with heart failure with reduced ejection fraction. Empagliflozin demonstrated a 25% reduction in the combined endpoint of heart failure, hospitalization, and cardiovascular death, regardless of whether patients had type 2 diabetes, along with a 13% reduction in heart failure hospitalization. A study on dapagliflozin revealed a 26% reduction in worsening heart failure or cardiovascular mortality and a 25% reduction in both cardiovascular death and heart failure hospitalizations, which lead the FDA to approve dapagliflozin for patients with heart failure reduced ejection fraction. Canagliflozin showed a 22% reduction in the composite outcome of heart failure hospitalization and cardiovascular death, along with a 33% overall reduction in heart failure hospitalizations. Ertugliflozin also reduced the risk of heart failure-related hospitalizations. In 2021, empagliflozin was found to significantly lower the risk of combined cardiovascular death or heart failure hospitalization in adults, regardless of the diabetes status, among patients with heart failure with preserved ejection fraction. Thus, it's approved by FDA along with dapagliflozin for heart failure with preserved ejection fraction. SGLT2 inhibitors function within the kidneys and are therefore believed to influence the nephropathic aspects of type 2 diabetes. Empagliflozin has been shown to reduce the risk of developing nephropathy by 39% and to decrease the likelihood of doubling serum creatinine levels by 44% compared to placebo. Trials investigating canagliflozin found a 30% reduction in the composite endpoint of end-stage renal disease, doubling of serum creatinine, or death from renal or cardiovascular causes. Dapagliflozin demonstrated a 39% reduction in the risk of declining kidney function, onset of end-stage renal disease, or death from renal failure, even among patients without diabetes. Additionally, in a cardiovascular trial involving ertugliflozin, a secondary endpoint showed that the incidence of sustained declines in estimated glomerular filtration rate, dialysis, transplantation, or renal death was 34% lower in the ertugliflozin group compared to the placebo group. Finally, we will compare the SGLT2 inhibitors based on their adverse effects. The most common adverse effects associated with these medications include female genital mycotic infections, urinary tract infections, and increased urination. Female genital mycotic infections occur in 5.9% of patients using empagliflozin, 7.65% with dapagliflozin, 10.65% with ertugliflozin, and 10.9% with canagliflozin, while urinary tract infections are reported in 8.45% of patients taking empagliflozin, 5% with dapagliflozin, 4% with ertugliflozin, and 5.2% with canagliflozin. And lastly, regarding the increased urination, it's experienced by 3.3% on those on empagliflozin, 3.4% with dapagliflozin, 2.5% with ertugliflozin, and 4.8% with canagliflozin. Thanks for joining us in this episode. We hope you found our comparison of SGLT2 inhibitors informative and helpful. If you have any questions or topics you would like us to cover in the future episodes, please leave a comment below. Don't forget to like this video and subscribe to our Daily Pharma channel for more insights into pharmaceuticals. Until next time, stay informed and take care.